Welcome, Dr. Stephen Stain. Dr. Stain is professor and chair of the Department of Surgery at Albany Medical College in Albany, New York, and a fellow regent with me at the ACS. Welcome, Steve.
Thank you, Steve.
I would like to speak to you this morning a little bit about the ACS-NSQIP module for COVID-19, but perhaps as a preface, you could give us a little thumbnail sketch of the history and utility of NSQIP.
So NSQIP has been around for, I think, at least 16 or 18 years. It came out of the VA system originally, but when the American College of Surgeons took it over, they've have provided a method for data collection with trained clinical reviewers that take preoperative data, and for patients who are having operations, they have a data collection system which allows them to use these variables to risk adjust based down to the operation, whether it's vascular operations, colorectal operations, elective emergency operations. And it's been shown to be able to reduce the complications if you apply the data from NSQIP to your own care and discuss it with your surgeons at your hospital. I think it's in about 800 hospitals in the country right now.
Thank you. Could you also please explain the new COVID-19 registry? What are the variables being collected in it, and how many centers are participating?
So it's the solicitation for centers just started, so I don't know how many centers are going to participate, but the heart of the program is objectively collected data by a surgical clinical reviewer, usually a nurse, but doesn't have to be a nurse, which goes through and extracts data from the electronic medical record, or in some places a paper chart, and then collects the demographic, physiologic data, also specifically for the COVID registry, things like procalcitonin, D-dimers, dates of intubation, whether they were made prone. And I think that data collection is the basis for us to try to get a handle on what's happening with these COVID patients. In NSQIP, they only collected on operative patients, but in this initiative that the college has started, they're asking the clinical reviewers to go and get data on all COVID patients in their hospital. So, for example, my hospital has, I think, 60 patients currently in the hospital that are COVID positive, and the clinical nurse reviewer would go and identify that information, extract it from the electronic medical record, and enter it into this broad database. The COVID registry is going to use REDCap, which is a pretty ubiquitous data base, which will allow it to be entered. And my hope is that for the patients that we've entered data on, we'll be able to extract data and actually see how we're doing as well. These clinical nurse reviewers who've been mostly doing elective cases, actually, because of the reduction of elective surgery, have time, many have stayed to be able to do this right now.
Interesting that the registry includes non-surgical patients, very different than the NSQIP registry. In other words, if a patient's admitted for a myocardial infarction or admitted for something unrelated to any surgery, if they're COVID positive, they're still going to be in this registry.
Yeah, I think the typical patient might be somebody who got admitted for respiratory distress, who's admitted to the medical ICU, but that patient has comorbidities, medical conditions that if we have that data from lots of hospitals, we can learn by analysis with risk adjustment, what are the factors which cause patients to do well or not do well based on what the data that and treatments that were used on those patients. So it goes beyond surgical patients take advantage of the infrastructure that already exists, the risk adjustment that already exists within the NSQIP, to use those strengths to be able to collect data relatively quickly and hopefully be able to do some analysis to identify what are the factors that affected outcomes in COVID patients.
So the ACS registry is substantially different than, for example, the COVID surge registry out of Birmingham, UK, that Anil Bangu has discussed with us in a prior From the Front Lines interview, because that registry is only surgery. Are you aware of any other COVID-19 registries for inpatient treatment?
There may be, I'm not aware of any, but there may be. But I know in my hospital, we have really, we do not have a structured way of capturing data. So we could go back retrospectively and look at how our patients did. But my hope is that we would be able to use this internally for our own analysis to see how we did. But I think the broader picture of having a, let's say it's 10,000 patient entered into this database, we can learn a lot about what worked and what didn't work in these COVID patients, and what comorbidities were the ones that perhaps led to them having poor outcomes.
The prerequisite for entry is presumably a COVID positive test, PCR or whatever.
I believe so. And the other thing that's about this registry, it's not only require that you are a NSQIP hospital. Other hospitals that want to participate, Dr. Koh, who is the director of the Division of Research and Optimal Patient Care, has said they are open to other hospitals that want to participate. So I think for fellows who may see this message, if they're interested in participating, Amy Sachs at the college is the person who they can contact.
Thank you. That preempted a question I was going to ask. With 800 hospitals participating, unfortunately, there's a lot of hospitals not participating. So being able to enter the data would be very helpful. Are there some cancer-specific fields as well, given the work that's being done by Heidi Nelson and the cancer programs?
Yeah, I'm just looking at the additional diagnosis that they have. I think there's some underlying diagnoses that are captured while the patient's in the hospital if they have underlying medical conditions, but also some things about how they got treated. The need for pressure support, whether they got treated with convalescent plasma, did they have interleukin blockers, how long they were intubated. So there's a wealth of information that can be entered, and because it's entered in a standardized fashion, I think will give us a lot of information to analyze.
Then another question is, what is the time commitment for entering data on an individual patient? I mean, I realize to some degree that's contingent upon the complexity of the patient and what's done, but what would you say is the time for data entry?
I think it depends upon, whether or not you already have the ability in your NSQIP hospital to extract data electronically. So let's say there's about 40 variables. I think in the past, with the electronic connections, more than half could be downloaded electronically directly into the data fields. My guess is and this is without any experience myself, it would probably take 20 or 30 minutes to get the rest of the data from the medical record.
The other consideration people always have, of course, is cost. And is there a cost to participate for a non-NSQIP hospital? While you're on that subject, perhaps you could just discuss the cost if somebody's listening and watching and they're not at a NSQIP program. What is the estimated cost for program participation in NSQIP?
So, my hospital's been a NSQIP member for about 15 years. So I don't know what is now, but it was about $30,000 per year to participate in NSQIP when we started. It may have gone up a bit. In addition, you have the salary of the clinical reviewer based on how big your hospital is and how many programs you have running. So I think that the cost for a non-NSQIP hospital is zero. There's no additional cost if you're a NSQIP hospital. For the NSQIP hospital, they already have the advantage of already paying for the salary of a clinical reviewer. We all hope that the COVID crisis will be at least waning in the next month or two. So we're in a critical time right now. We can get some very, very useful data. And I think that data can be used for all of us to figure out how these patients were treated best.
Then there's also consideration of the veracity of the data, and NSQIP programs undergo periodic reviews. What is the plan for data verification from non-NSQIP hospitals who are entering data in this registry?
So I do not know whether there will be future or ongoing verification of the data, but to be a surgical clinical reviewer, the NSQIP nurses, they get audited and they have to have, I think, less than a 5% error rate of what their data is, and they've already been audited to become a surgical clinical reviewer. You know, my guess is that this data will be collected largely in the next few months, and NSQIP may have some means of auditing their data. In the past, they would have to send in some of the records of the patients they audited, and they would be checked to make sure they're adequately audited. For NSQIP, some of the things that they, surgical NSQIP things are for wound infections, urinary tract infections, pneumonia, those diagnoses. Much of the data here is stuff that is, relatively straightforward. Numbers such as, glucose, hemoglobin, white blood cell count. I don't see on the data list that they have, or did they get hydroxychloroquine? Did they get antibiotics? I think those things are pretty straightforward, and the clinical reviewers will be able to do them pretty well.
Well, it certainly seems like a robust source of data, and one can't go a single month without opening a surgical journal that doesn't have some high-value article with a large denominator of patients from NSQIP. So I imagine this registry will certainly be the same. Since you're already a participating hospital, and you, as you mentioned, have patients, COVID positive patients in your hospital, what's the mechanism for entry? Does the individual patient get entered on admission to the hospital and then daily updates, or is it something that's done only at the time of discharge in retrospect?
So typically for the NSQIP patients, they are identified anytime during the hospitalization, and then once they're identified, the surgical clinical reviewer goes into the medical record and extracts data out of that record. So my guess is it will be a similar data collection. We're usually reviewing them, within 30 days of their admission. But if you had the time now, if the SCR had the time, they could be, reviewed either concurrently or at the time of the discharge. I think the more data we get into a system for analysis, the more conclusions we'll be able to make about what worked and what didn't work for the various treatments. I just want to, first tell the fellows that this is an important service we can do to learn more about COVID-19. And I think it's not really my work, it's the great work done by Cliff Coe's team, who's the director of the Division of Research and Optimal Patient Care. I think it's an easy mechanism to join, and I think I would invite all of the fellows of the college to investigate whether their hospital wants to participate to help gather this important information.
Well, thank you very much. Thanks for highlighting the great work that Dr. Coe has done for many years. It's also important to hear from you that it's easy to use on our end as surgeons entering data. So thanks for highlighting the ease of use. And thanks, Cliff, for all the work you do all year on the Division of Research and Optimal Patient Care. I certainly look forward to learning what comes of the registry. Thanks for all the work you're doing with the registry, supporting NSQIP. I look forward to seeing you at an upcoming Regents meeting when we're allowed to participate in person in the future. In the interim, wish you and your loved ones sustained health and safety.
Thank you.